Hi, I'm Baron Metz, Professor of Anesthesiology, and I'm here to tell you about my new book called Waking Up Safer, an Anesthesiologist's Record. This book is written specifically for the layperson to inform you better about the wonderful specialty of anesthesiology, which is much misunderstood by the average individual, most believing that it is sleep, the god of sleep behind me, rather than coma or chemically induced coma using agents like propofol and the volatile anesthetics like isoflurane. Now, I've entitled this particular video, Is Anesthesia Safe? Now, anesthesia is inherently dangerous because we're administering lethal drugs to unconsciousness or coma. And these lethal drugs do not just depress consciousness, but they depress many vital functions or critical functions within the body. For example, the cardiovascular system and the respiratory system and lungs. So if we, for example, to give unopposed halothane, either through a mask on the patient's airway or through intubating a patient, and just let the patient breathe halothane, 5%, this is what would happen. The respirations would slow, the heart rate would slow, the blood pressure would drop, eventually the patient would turn blue, the heart would stop completely, and the patient would die. Similarly, if we give a relative overdose of this induction agent propofol to the patient, the blood pressure would collapse, respiration would stop, and the patient would die. Now we use another lethal drug, which is called a muscle paralytic agent like this rocuronium. We give this to stretch the muscles when we want to intubate the larynx, and also to paralyze the patient so that we can open the abdomen so that the surgeons can have proper access when they do surgery. In the context of anesthesia, these drugs are relatively safe, but similar drugs, intravenous induction agents, as well as muscle paralytics, are used for the lethal cocktail that are used for lethal injection in the United States. So out of the context of anesthesia management, these are lethal drugs indeed. However, in the context of properly trained individuals practicing anesthesia, it's like anesthesiologists and anesthetists, we are trained to remedy the untoward effects of the deadly drugs that I have just described for you. Now, I took flying lessons once to learn to be a pilot, and there are very strong parallels between flying and anesthesia. In anesthesia, for example, we induce the patient while the pilot takes off the plane. In anesthesia, we maintain the anesthetic with isoflurane or halothane while the pilot cruises at an altitude, expecting some turbulence along the way as we do during surgery. And in anesthesia, we have the eduction or recovery phase from the anesthesia, just like the pilot has the landing problems that they have to contend with on landing the plane. So, taking off, cruising, and landing are very similar in anesthesia as they are in flying. So much so that one of the chapters in the book, Waking Up Safer, I have entitled Flying the Anesthesia Machine. Just like a pilot who wants to take off his plane, delivers full thrust and slowly pulls back on the yoke as he wishes to elevate his plane as he gets to the end of the runway, committing the patient to flight, so too an anesthesiologist induces the anesthetic to the right dose and commits the patient to coma and all of its consequences. There is no going back. We usually anticipate a smooth flight with little turbulence when we induce anesthesia, but we always have a backup plan. We call this Plan B. Just like pilots are trained that as they take off, they need to look for a landing spot, so we are prepared to deal with the consequences of our anesthetics. Drops in blood pressure, we would treat with something called phenylephrine or ephedrine to bring back the blood pressure and the heart rate if that is required. This is a dose-response relationship, so we adjust the doses according to the particular patient and the depth of anesthesia that has been administered at that stage. Similarly, we are always looking out for the potential difficult airway that can only be established as soon as we've induced anesthesia. So a difficult airway is a situation where we find it difficult to manage the collapsed airway, and as a result of that, the potential for the patient is to become hypoxic, i.e. to have a loss of oxygen going to the brain. The take-home message here about flying and anesthesia is that they're both inherently dangerous. But we have made anesthesia much safer through tapping lessons from aviation, such as the use of checklists, as well as to use human factors design in developing approaches to that difficult airway that I just told you about. We have used human factors design principles to create an approach that we call the vortex approach for airway management. So as I explained to you earlier, if we have here the airway in a patient, you can see that this is actually quite easy to see the glottis. We often access the glottis where we wish to place a tube through using, of course, a laryngoscope. It's a conventional laryngoscope, and we can access the glottis like this, and really lets us see quite nicely what's going on. But this is not always predictable, because patients have different physiognomies, that is, their faces are very different. Every individual is different from every other one's, and we can't always predict what we would do. And sometimes we will go in, try and intubate the patient, and we really can't see what's going on. We can't intubate. So then our next emergency measure is to place an LMA, a laryngeal mask airway, to see if we can now secure the airway, but still sometimes this fails. So what the human factors design algorithm has allowed us to do with the vortex approach is to realize when we're in real trouble, or at least the patient is in real trouble, as they become increasingly bereft of oxygen going to their brain, their heart rates is slowing. We now have systems approach to solving that problem by cutting in the neck right here during the trachea, so that we can introduce a device here and so provide allow life-saving oxygen to go back to the lungs, hopefully in the nick of time, so that no brain damage occurs to the patient as a result of this difficult airway problem that we just dealt with using a human factors design approach. So the question for you is, are you safer today than you were before, as anesthesia developed in its human factors design approach, in its enhanced training of specialists in anesthesiology and anesthetists, as well in the new drugs, equipment, and monitors that I've discussed with you? So are you waking up safer after an anesthetic? Yes, intracontrovertibly yes. Over the last 60 years, since the time that we've properly been able to measure this, there's been a 90-fold improvement in anesthesia safety. But are you safer in every instance? No. The reason for that is that there's interpersonal genetic variability, as well as many patients are really very sick and do not take anesthesia at all well. So the outcome is not always positive and is not always predictable. You are, however, much safer than before, but you will never be safe as flying a commercial jetliner. But through all of the progress that I've just described in this book and in the videos that I've held and developed, you are certainly steadfastly safer today than ever before. My ask of you is that you will read my book, Waking Up Safer, an anesthesiologist's record, which will allow you to prepare yourself for the inevitable next anesthetic that you will have. And also, my ask of you is to go to my website, baronmetz.com, to see a few more of my videos which will help explain the much misunderstood specialty of anesthesiology. I thank you for your attention.